Hello everyone, hope you're all doing good. Guys, this is Dr. Sowmya here, welcoming you all to the RRR series of the most important module, which is labor and delivery. Obviously, the thing about the labor and delivery is this is a module which deals with day-to-day activities, day-to-day cases, scenarios. So that's the reason you need to remember one thing, that there is no black and white rules when you apply the current evidence-based guidelines for the scenarios given to you in the exam. So to start with, remember to embrace your awesomeness because each one of us are awesome in our own way. So let's work on our strengths and let's strengthen our strengths and work on the weakness to make it, again, your own strength as well. So to start with, hot topics which you shouldn't be missing on. Obviously, the intrapartum care is the most important one. Then you have assisted vaginal birth, breech, VBACs, and card prolapse, cesarean section, preterm labor, PPROM. So all these things are important. Obviously, intrapartum care for like you can talk about the low risk pregnancies and the high risk pregnancies, and obviously the multiple pregnancies, preeclampsia, and high risk pregnancies like cardiac disease. You really need to be aware as well. The minor changes which you need to do, and what are the oxytocin, what is the management of third stage active management, those minor changes which you really need to be aware of. What am I going to do today is to help you to understand a bit of a concepts and a few activities considering the time frame we have got, and also a panoramic view of the labor and care delivery altogether. I have given a little more importance to the CTG because few of you are really worried about it, and correct approach of handling the questions whenever it is given. I'll be more making this probably series or this session particularly more of conceptualized one. So as you all know, fetal heart rate monitoring can be done from a Pinard stethoscope as in low risk pregnancy. But if that is not there, or if you're not comfortable, you can go for the handheld Doppler. And in high risk pregnancies or during this intermittent auscultation of Pinard and handheld Doppler, if you find it probably an audible deceleration, or in case of high risk pregnancies, we would want to do a continuous CTG monitoring, right? Or if you have any time of suspicion, you generally do a CTG to make sure that the baby is okay inside. So this implications and how it goes. Generally, the paper speed is at 1 centimeter per hour, and any CTG provided to you always start in this with the mnemonic of Dr. C. Bravado, just to remember the facts. So obviously, if the first and foremost is defining the risk, C is for the contractions, BRA is for the baseline, right? Variability, acceleration, decelerations, and finally the overall impression. And for the European board, they do follow FIGO 2015 classification, which I'm going to talk about in a while. So here you can see what do you understand by telling 1 centimeter per hour? Basically, whenever you are reading the CTG, so you need to know that if it is 1 centimeter per hour, then this one box will be 1 minute. Okay. So this box from here to here, it will be 2 minutes. From here to here, it will be 3 minutes. So that's how you calculate the minutes for you to understand how long the deceleration is. And how do you calculate the fetal heart rate? You could see here, it's on the vertical axis or the y-axis. You've got 180, 190, 200. See, actually, basically, this is 180. This will be 190. This will be 200. So let's look into one of these. So if you could say that, for example, in A, there is a deceleration. Deceleration when it is more than 20 beats per minute for more than 20 seconds. Obviously, so what is the fall from 180 to 150? So there is a 30 beats per minute fall, which is definitely you can call deceleration. And how long it is lasting? As you know, this is 1 minute and this is 30 seconds. So that's the reason this would be something which lasts for 90 seconds. Okay. So there is a deceleration which is falling for 30 beats per minute, lasting for 90 seconds. Let's look into the bigger one. So here you can see, let's look into the minutes first. It is starting from here. So 1, 2, and 3. So there is a deceleration of 3 minutes because it is coming back here. And what is the depth which falls? For example, fetal heart rate. So it is from 120 to, this is 90. So 120 minus 90 is 30 beats per minute. So obviously it is a 3 minutes deceleration falling for 30 beats per minute. So this is how you interpret your decelerations are the accelerations, are the time and the duration, and also how far it is falling. Whenever the deceleration lost, for example, here, the deceleration has picked up, but if it is falling continuously like this, once it crosses more than 3 minutes, you call that prolonged bradycardia, which is a pathological feature. Okay. Okay, so let's move on to the next one. The tracing classification, as I mentioned, it is according to the figure 2015. So they do mention normal heart rate is 110 to 160 and the variability is 5 to 25. Decelerations, nothing should be repetitive. And in this case, you really don't need to do anything. And then comes the pathological, because suspicious is in between both of them. Pathological, when the heartbeat is less than 100 beats per minute. Obviously, reduced variability, that is less than 5 or more than 25, or the sinusoidal pattern, which we are all aware, are repetitive, late or prolonged deceleration for more than 30 minutes, or even if it is 20 minutes, but the beat to beat variability is less, you consider them as pathological features. And obviously, pathological is not nice to have. That indicates there is a high probability of hypoxia. You have to do an immediate corrective actions. And probably you need to remember here, still FBS is still done in a couple of European countries. So you need to remember that as well. Okay. So anything between these two features would be suspicious. Suspicious means there is already an element of hypoxia, but there is a low probability. It is not that for like pathological where you are sure short of hypoxias. So now let's look into this. And decelerations, as we mentioned, when do you say repetitive? For example, if you have 4 contractions in 10 minutes, if the deceleration is for 3 contractions, that is more than 2, then you call it repetitive decelerations. Okay. And remember, if accelerations are there, it's a good sign. But absence of accelerations in labor is not of any significance. Okay. Hope that's clear. Let's look into a couple of CTGs more. So if you could see this fetal heart rate, so this is around, see, because you usually it keeps on varying at in each point, you can see it is 126 here, because this is 140 here and this is 120 here. And you can see here 128, 140, 126. So you can keep on looking into the heartbeat, and generally the heartbeat is the more troughs which go through. So it is still a normal scenario here. And what do you mean by variability? Variability indicates the intact autonomic nervous system. So if there is a decreased variability, you should be really worried that his autonomic nervous system has been hampered long back, which indicates chronic hypoxias. Especially in case of STAs or IUGRs, you should be really careful. And what is the variability is the average amplitude which you take in 1 minute segments. That is what it is. And as you know, it is between 5 to 25. Okay, that's the normal amplitude which you take are the normal variability. Then when you come to the decelerations, obviously there are a couple of decelerations which you, 3 types of deceleration. Early, which is a mirror image, okay, of the same, and late, where it starts later to the contraction. I would show you in the next slide. And variable. Variable could be with concerning characteristics and without concerning characteristics. Out of these, early decelerations are still okay to have. Variable decelerations without concerning characteristics is okay. But late decelerations always indicates hypoxia. Okay. So this is what we mean. What do you mean by early deceleration says? Basically, you can see that they start with the contraction, okay, and they end with the contraction. Okay, so that is what, it's a mirror image. And generally, this is due to, for example, head compression. When the head is getting compressed, the baroreceptors through the vagal nerve stimulation, there is a drop in the fetal heart rate, which means early deceleration. Late decelerations. The characteristic of the late deceleration is generally at the peak of the contraction, the dip starts, and once the contraction is over, the nadir will be coinciding with that. And way after the contraction is over, the recovery starts. So you can see the deceleration is here and the contraction is here. It is called late because it is later than the contraction. And it is an ominous sign. It is really not good to have, which indicates, because it is mediated by chemoreceptors, so indicates that it is not a good sign to have the late decelerations. When you come to the variable, the reason why it is variable is it is neither early nor late with respect to the contractions. Generally, you can talk about the decelerations with respect to the contractions. So ideally, you could see here, it is starting and ending within the contraction, but it is not a mirror image. And variable decelerations are most commonly seen in labor due to cord compression. These are the most commonest one, which you can see. However, there are variable decelerations with concerning characteristics which you would be more worried of. For example, you can see generally when the heartbeat is falling, there will be always a bit of increase in heart rate, then it falls, and again it increases and comes back. So that is a normal thing. But if that happens, it's a concerning characteristics. Or see, generally here you can see the level of shouldering, so it should be here, but it is overshooting. That's the baby is really trying to compensate for whatever for the deceleration. So that is not again good. And whenever there is a deceleration, you can see here all beat to beat variability is maintained. That is, it is maintained. When it is not maintained, when it is, if this was smooth like this, again, it is concerning one. And generally, you can see the recovery is immediate. But here, the baby is trying to wash off all the acids remaining and then coming up for the normal one. So this is a late recovery. Again, it is not a good sign. And biphasic deceleration. As the baby, the heart rate falling, it is trying to pick up. Again, it is falling, it is trying to pick up. So this is again not a good sign. Whenever you see these variable decelerations are really not a good sign to go ahead with. Okay. So few CTGs to have a look into. So what is happening here? What is the heart rate? It's around 168 and accelerations are there. And there are minute decelerations which are early and they are non-repetitive. So the variability is normal. See, because there are these things which can categorize this to suspicious. In suspicious or late or pathological, you always start with conservative measures, turning to left lateral and adjusting the syntocinon, or if the contractions are more. So you have to do all those conservative measures and you can do a fetal scalp stimulation. And in cases of pathological one, you really need to be careful to do about the FBS. In a couple of countries, it is still valid. Okay. So this is something which you need to know. There is one more CTG. That's why I came to this. So here what's happening? Obviously, it's a very obvious one. It is pathological because there is a prolonged deceleration. But let's look it into the interpretation. Late and prolonged deceleration. You can see here also. Okay, there is a prolonged late and variable deceleration. There is decreased variability, recurring hypoxia. You can see there is a coupling here. Okay, the point is when the heartbeat is falling, there is a coupling here. So it could be because of excessive contractions or hyperstimulation, which are tachysystole you can call. So you have to avoid that. Okay, and ask it to stop pushing and give a retocolytic, which could settle down the things. Okay, and obviously if it's favorable to go for vaginal delivery, you can think of going ahead. Okay, so obviously this is a pathological CTG at this point of time. And we were talking about hyperstimulation and tachysystole. The point is tachysystole is when the contractions is more than 5. Couple of guidelines mentions different for primi and multi, but once it is more than 5, you can think of tachysystole. Hypertonus is if the contraction is lasting more than 2 minutes. Either of this which is lost, which is coming up with, for example, tachysystole or hypertonus presenting with decelerations, as you can see here. Here you can see 1, 2, 3, 4, 5, 6 to 7 contractions are there, and there is deceleration. This is what is called uterine hyperstimulation. Just for the number of contractions or the prolonged contractions doesn't make it hyperstimulation. If it is associated with fetal heart rate abnormality, then you call hyperstimulation. Obviously, for this, what do? You look for whether she's on oxytocin therapy, you have to stop. If she's on any prostaglandin delivery system, you have to remove that and give a tocolytic as well. Okay. And couple of flash points about the CTG. You could get this as CTG, or probably you could get this as you could get this EMQ or an SPA. So somebody who is on warfarin, high-risk pregnancy, she came in labor with 2 centimeters dilated, but she couldn't stop. So if you need a cesarean section, obviously, because it can cause epidural and subdural hematomas, you go for cesarean section if it is required under general anesthesia because they couldn't stop warfarin. Next one here, what is happening? It's a case of APH with a maternal compromise. You can see pulse 120, blood pressure is 90/50, tachycardia, hypertension, post-stated. There is an element of hemorrhage, and you can see this is a sinusoidal pattern. Obviously, unless she's fully dilated, where you can put forceps and take it out. Here, it is 2 centimeters dilated, membranes intact. So the next best option is start resuscitating the mother. Don't forget the mother. Start resuscitating the mother and then shift her for category 1 cesarean section. Okay, so that's the best for both mother and the baby. And this we have covered. And the next thing is all about, okay, again, one more example of what to do in this. A Ruby 34-year-old primary, 38 weeks, 6 days, induced with PROPES, that's the vaginal prostaglandin delivery system, and midwife is worried about the CTG. Obviously, if you apply Dr. C. Bravado, the first thing is there is a risk of induction, and the contractions you can see here 1, 2, 3, 4, 5, 6, and you can see the decelerations with that. So definitely there is a hyperstimulation. So what do? I remove the PROPES as well as give terbutaline. Remember, if it is only hypertonus and takisystole, you just remove the prostaglandin system. But here, because the baby is already getting compromised, you have to give a tocolytic to relax the uterus. Okay, perfect. Hope this is helping. Yes, a bit about the images, if at all, if it is given, how do you go for in the EMQ? You can see a 34-year-old, 39 weeks, admitted in labor with regular contraction. She was found to be 5 centimeters dilated. Later on, even after 4 hours, it remains the same. Fetal weight seems to be normal, and there is a family history, but here the CTG looks normal. But I'm worried about the delayed progress of the labor. So obviously, if the membranes are intact, the first thing which I would be doing is amniotomy. And obviously, if at all, whenever I do an amniotomy, I must make sure to repeat the vaginal examination in 2 hours, unlike the oxytocin, which we repeat in 4 hours. So that's the reason I've chosen D instead of F, because amniotomy, as it releases the natural prostaglandins, I have to look into her earlier than the time which we give for oxytocin. So after amniotomy, it is 2 hours, and after oxytocin, you can examine after 4 hours. Okay. Yes, this is what I was trying to tell. Whenever there is, irrespective of the parity, you do we are all talking for the low risk pregnancies. Whenever there is a delayed progress of the labor, if it is less than 2 centimeters in 4 hours, the first thing which you examine, and if the membranes are intact, go for amniotomy. And whenever there is amniotomy, you have to do a vaginal examination after 2 hours, as I discussed before. And definitely you have to look into, if the dilatation is less than 1 centimeters, it is still delayed. There was a suspicion of delay. You do an amniotomy, you repeat the examination after 2 hours, but it is still not going the way which you wanted. You can start oxytocin and you give a solid time of 4 hours. Okay, because it is iatrogenically, you are adjusting the oxytocin rib to get the maximum contractions. So if that even after 4 hours, when you examine, if it is less than 2 centimeters per 4 hours, you really need to think there could be an element of CPD, or probably she will be going for CS. If it is more than 2 centimeters, you let her continue the normal labor. So basically, it's all about understanding and giving the sufficient time in a low-risk pregnant woman. Hope this is useful. Next, the duration of the labor. See, basically, before there was a consensus, irrespective of the parity, the pregnant woman who is in second stage of labor should be delivered by 4 hours, which is replaced by, based on the parity, it will be for a nulliparous who is not on any epidural, it will be by 2 hours she has to be delivering, and multiparous it will be 1 hour. However, if they are epidural, because they lose the urge of pushing, you give 1 more hour for the time duration. For example, it is 2 + 1 in case of nulliparous who is on epidural, and 1 + 1 in case who is on epidural in multiparous. Okay. And remember, these deadlines are trying to tell you that by this time you should start preparing her for delivery. However, if somebody is going to deliver very soon and this time is crossed, just because the time is crossed, you don't jump and put the forceps unless there is a need for the baby, or unless you think she's going to take more time than expected. Okay, I have a couple of examples to share with you guys. So, which I will be doing according to the time parity we will be talking about. And don't forget to revise the mechanism of labor. As obstetricians, we really need to know about the basic mechanism of labor for occipito-anterior, occipito-posterior phase. And as you all know, for bro, as the mentovertical diameter, the engaging diameter is mentovertical, which is more than the longest diameter of the pelvis. So obviously, there is no mechanism for bro. But you really need to know the cardinal moments of the labor. Instrumental delivery. Okay, as you all know, forceps and vacuum both can be used. In vacuum, you can use silastic cup or the metallic cup. So, and also you can use the kiwi cup. And forceps, it depends on the station. You could use outlet, low, mid cavity, rotational forceps based on the place and the position which you are using it. So, a couple of things which I want to bring your notice to. Outlet forceps are the easiest one which you can do in the labor room. Low forceps, unless it is non-rotational, like you need not rotate from occipito-transverse to occipito-anterior or occipito-posterior to occipito-anterior, you can do it in the labor room. However, if you think this has to have a difficult rotational deliveries, you would still shift it to the theater. Mid-cavity. There is a very, I would say there is a myth which says, which majority of the people believe in, all the mid-cavities should be done in the theater. Ideally, all difficult mid cavities should be done in theater. But if a multiparous lady on a good analgesia, without any malposition, you can still do in the labor room. So that is what I'm going to talk about as well. Because whenever you mention trial of labor, it is usually to shifting to the theater and doing. So mid cavity can be put in labor room if the conditions are favorable. So, and the VT risk assessments for all of them. There are a couple of things which you guys need to remember. Mid-cavity rotational forceps. It is because rotational forceps, you're giving a score of 1. Prolonged labor of 36 hours, operative delivery. Here, you're giving score for prolonged labor. Simple lifter to operative delivery, no need to do any score unless she has other risk factors. Quick progress with difficult operative delivery, obviously she will have a score of 1. So whenever you have an operative delivery, for all the pregnant women who are laboring with or without operative deliveries, obviously VT risk assessment is a must. But here I've given this example to make you understand what is the importance of giving the scores. It is not that forceps or vacuum will give the score. It depends upon the other features as well. Okay. Few tips whenever you solve the questions on labor, especially laboring women, look at the parity, whether she is primary, multiparous, gestational age, preterm, postterm, term, analgesia, internox, which is nitrous oxide and oxygen, or pudendal block, or epidural, station, 0 or -1, or +1 or +2, position, occipito-anterior, occipito-posterior, whether caput molding, because sometimes if the caput molding is severe, then there is always a high risk of failure of vacuum. Couple of scenarios to discuss. For example, here there is a primary who is a term gestation, low risk, progressing well, head on perineum, no concerns, otherwise 2 hours over. So she's with every push, if there is a descent, just because she's 2 hours over, you don't jump and put the forceps. It's almost there, so you let her push. Okay. So this is what I was trying to tell. Everything, there is no black and white rule. You have to customize according to the patient in front of you. The next one, multiparous at 39 weeks on epidural, occipito-anterior, epidural, she's on epidural, 2 hours over, station is at spines. So here what is happening? So because somebody, it's a multiparous lady who is occipito-anterior, who is on epidural, but obviously 1 + 1 hour is over. So do you think giving an additional time would help her to deliver on her own? No, she would definitely need an instrumental delivery. But because it is occipito-anterior, multiparous lady on a good analgesia, I can do this forceps because this is non-rotational mid-cavity forceps. I can put this in the labor room. Next, multiparous 38 weeks, no pain relief, head at spines, occipito-anterior. Here again, the difference is she is not on any pain relief. So head is at spines. So whenever you apply forceps, it would be very difficult to pull the baby from the spine. So that is the reason you take her to the theater. Even pudendal block is very difficult at this point of time. So you take her to the theater and give her combined spinal epidural and do the forceps. Practically, analgesias are very important, so do not forget. The next one, 38 weeks, fully dilated, pushing for 2 hours. She's fully dilated, left occipital anterior vortex 1 centimeter below the ischial spine. That's +1 with capital molding. So here again, obviously, they haven't given the analgesia, but either the case, she has already been multiparas pushing for 2 hours. So you really need to go for the instrumental delivery because I think even if it is +1, it won't be as difficult as spine. So you can go ahead with the instrumental delivery in the room itself. The next one, multiparas epidural. I think this I had already discussed. The next one, 37. Okay, so this is important. Multiparas term, occipital posterior at spines on epidural analgesia. Okay, so here what's happening? Here the point is you can see that she's BMI is more and she's obese as well. So in this case, you really don't want to have there is always a high risk of failure. So that is the reason you will be going ahead with the trial of instrumental delivery in theater. So basically all these scenarios, whenever there is a right occipital posterior, okay, right occipital posterior, you need to remember there is always a high risk of failure, especially in obese women. For that reason, even with good analgesia and also rotation is required. So you shift it to the theater. Hope these 6 scenarios have given an idea where to do what. Obviously, very important, shoulder dystocia, obstetric emergency. As you can see, this is the first maneuver which you see the MAC-robots asking 2 midwives to stand on either side at the count of 1, 2, and 3. You would flex and abduct the maternal thighs. With that, what happens whenever there is a flexion and abduction, you can see the relative motion of the pelvis towards the head, which can release the stuck anterior shoulder. And obviously, if that fails, the success rate is 90%. If that fails, along with that, you can keep the suprapubic pressure from where the baby's back is there. Shoulder dystocia is something which you need to treat very, very quickly. Otherwise, the baby will be hypoxic. Okay. So what couple of maneuvers to understand how to go about. Here you have a low-risk pregnant lady in her multiparas, and so like she is with midwife, and they have noticed that there is a shoulder dystocia. And she has tried MAC-robots and suprapubic with no benefit. So for all practical purpose, you have only the midwife there. So how do you go about that? Is Miss Angel is the only one who is there. In that case, the next thing, ideally, the next thing could be the internal maneuvers, because the midwife is all alone. You can go for all 4s. In that case, what happens? The woman would lie down on the knee and the chest, knee and the actually elbows, and the anterior will become posterior. All 4s again has a good success rate because midwife is alone. She can try as the next best maneuver. Here, what's happening here? The low risk multiparas again referred by midwife to the hospital. So she is in the hospital, and you can see the baby is macrosomic and there is a shoulder dystocia. First maneuver will always be MAC-robots. After calling for help, you check whether it is bilateral shoulder dystocia, then you go for MAC-robots. Okay, very clinically oriented scenarios which you need to remember. Okay, whenever there are EMQs, people are really worried what to do, how to do. But if you follow these tips, read the lead-in statement first and look into the gestational age, parity, analgesia station position, and how many hours she has been pushing her in labor. And have a look into the CTG. If they haven't mentioned anything about the CTG, that means to say that the baby is doing good. If you do this, then definitely the EMQ solving becomes very easier. Let's have a look into this. This is a very lengthy scenario. Whenever you get this, the first thing which you need to do is read the lead-in statement. Make your lead-in statement as a friend. So here what they're telling me that there are different options for the intrapartum management, and I need to choose the most appropriate management. Okay, then I would go for the scenario. So what is there? As I read, I tend to mark so that it becomes easy for me. So here I have a lady who's 23-year-old, okay, multiparas, that's fine, has undergone induction of labor at post-stated in her first pregnancy. Okay, so this is not multiparas, this is a primigravida who is in her first pregnancy, Antenatal care was complicated with small APH at 34. So post-dated trimmy at 34, she was admitted with, at 34 weeks, she was admitted with the APH and blood group is positive. So that's fine. Now, probably she has been induced with prostaglandin gel and labor progressed well. Cervix was 5 centimeters dilated, meconium, but the CTG is fine, okay? And epidural analgesia is there. 2 hours later, the fetal head is 0/5 palpable, cervix 9 centimeters dilated, left occipita anterior, minimal caput bulging. CTG had a baseline of 165 with no baseline variability. No baseline variability, no accelerations or decelerations, and a small amount of vaginal bleeding. Fetal heart rate unexpectedly drops to 85 and does not recover. So what am I dealing with? I am dealing with a post-stated lady, post-term pregnancy with a history of APH, induced with meconium stain laker, and she's having a CTG which was normal before, but now 9 centimeters dilated, and there is a bradycardia, but I don't know, it says it does not recover. So what do I do generally? The next first thing which comes to my mind is the cesarean section or the operative delivery. So because the mother has to, you have to make sure that the baby is out as quickly as possible because some element of bleeding is also there. Now, generally, what do you do whenever you come across this patient in your real scenario? You shift to the theater, assess her, and then if she's not fully dilated or not fit for operative delivery, you go for cesarean section. So I have an option of cesarean sections here. Obviously, this will be category 1. But I would want to look if I have an option for forceps or vacuum, or probably whether there is anything to review. So if you could see this option, immediate transport to the theater for reassessment with a view to delivery. Delivery doesn't mean that it has to be like an operative delivery, but I want to take out the baby. That's what it means. So looking into the scenario, that is the best one which I would go about. So that is the correct answer. Okay, so obviously you will be going for operative delivery or cesarean section, but before that, I need to make sure that she's not, because remember, it is not easy to do a second stage cesarean section. So first I would want to see the way to quickly take out the baby. That's the reason I is the correct option. Hope that helps, guys. Fantastic. So let's move on. Again, here, when I have this big question, this is single best answer. I would want to do a cover test. But whenever I have a big scenario, I always start with this. What is the most appropriate management plan? Okay. The patient whom I have here is, I'm the specialty trainee, Nalli Parasuman. She's pushing for 80 minutes. That's around, okay, 1 hour, 20 minutes. She has a low risk pregnancy. She wants a water bath, adequate progress, fully dilated 2 hours previously, but pushing had been delayed until she felt the urge. She's now out of the pool. CTG commenced, tired, and no longer coping. On examination, appropriately grown fetus with no head palpable abdominally, vagina examination, fully dilated. Head is a +1, that is 0 to +1, so mid cavity. Left occipital transverse LOT with 1 plus capital molding, Liker is clear, and CTG reassuring. The thing is, definitely this woman needs a helping hand. But what do you want to do? Forceps delivery in room, theater, ventus, or CSR, continue pushing. This is done. Cesarean section could be if it fails. So I'm not sure whether she's going to deliver or not. So what do I do is I would shift her to the theater, do a trial of instrumental delivery because I'm not sure whether she's going to deliver or not. And obviously there is no element of analgesia given here. And you could argue, okay, she's actually has been pushing for 80 minutes and fully dilated. So this is more than enough, actually. So like around 3.5 hours she has been here. It's a time to cut short the labor. So how do you go about? You could say I would put forceps in the room. But the point is, this is not something which you can be very sure that she's going to deliver. So please shift it to the theater and try there. If that doesn't work, you can think of cesarean section. But the first thing, trial of instrumental delivery in theater. Obviously, diameters, you guys need to know which one goes where. The engaging diameters, the basics. Okay, sometimes they could ask you this, which I was mentioning. There is no mechanism of labor for this. The cesarean section is the best bet for that. And when you have the pH values, because FBS would still be done in a couple of the European countries, you do FBS in case where you think you want to give some time and make sure that to understand the acid-base status of the baby. Here, the CTG was non-reassuring in an obese woman and the pH shows 7.23. In this case, she is also fully dilated. Okay, let's read the scenario. Primary with an BMI of 38 at term, effective epidural, 4 centimeters dilated at 7, 9 at 11, and 13. The membranes ruptured spontaneously, thick fresh meconium, fully dilated cervix, vertex was just below the spines and direct occipiter posterior. There is no head palpable. The CTG was non-reassuring, but the fetal blood sampling shows pH of 7.23. So if you could see why I should be waiting for her, because even though you wait, there is already, it is in the direct occipital posterior in an obese woman. So obviously she needs your hand. So that is the reason you would be going ahead and doing. It doesn't mean that you would only do FPS to understand whether you can wait for some more time. How is the baby? Making sure that you're going to deliver her normally. When that doesn't happen, for example, in case of card prolapse, abruptions, and when you know that she's not going to deliver normally, then you can go ahead and cut short with the instrument. The next one, 42-year-old, cardiac disease, class 2, that's NYHA class 2, IVF treatment, spontaneous labor at 39, cervix 6 centimeters at 6 o'clock with ruptured membranes. At 10, cervix was fully dilated and vertex was 2 centimeters. That's below the spine, so plus 2. So ideally, CTG was normal and she has an urge to push. Ideally, whenever there is a cardiac disease, we always think, let's cut short. But if as the guideline mentions, unless she has a class 3 and class 4 and she has some difficulties, you have to be going ahead and allowing her normal delivery. However, they do have a low threshold for instrumental delivery. So it is all customized for the patients. It doesn't mean that class 2 and class 1, you shouldn't be putting the forceps, but it has to be customized. Remember, unnecessary operated deliveries and cesarean sections to be avoided. Okay. The next one, this is one of the exceptional cases where multiparous, previous normal deliveries, there are twins, DCDA twins. Okay, she's present at labor at 37 weeks and vertex first twin and second twin to be again with a longitudinal lie, membranes rupture spontaneously, CTG remained reassuring. Then at 1640, CTG became suspicious and despite adequate contractions with oxytocin infusion, the head remains 1/5. Vaginal examination was vertex 1 centimeter above the level of the ischial spine. So here, the first baby is delivered and the second baby, they are waiting. Ideally, you can wait for 30 minutes. But here, what is happening? The baby is showing that it is not very well. It is not happy inside or it is becoming hypoxic. So you can definitely go for instrumental delivery. But here, it mentions for the second twin, the second baby is, which is about to be delivered, is -1. Ideally, for all other singleton pregnancies, you shouldn't be going ahead and putting the forceps or the vacuum here. But this is an exception for the rule where for the second twin, you can apply the ventouse when it is above -0 in a very exceptional cases like this. In a twin delivery, you can go for ventouse, not the forceps, ventouse. This is a tricky question. And remember, definitely the immediate thing would be you will think of going ahead with cesarean section. Okay. But usually in these cases, ventouse is the most straightforward option. So again, I will again reconfirm with you guys, it's only an exception in the second twin where you apply at -1. That is vacuum, not the forceps. Okay. So this is an exceptional case. Next. Okay, so what's happening here? Couple of flash or the random scenarios. Primary fetal assessment is reassuring that CTG looks fine. 9 centimeters dilated, position is mento-posterior. In that case, mento-posterior, as we know, it is difficult to deliver, so you go for category 2 cesarean section. This mento-anterior as a mechanism of labor, mento-posterior doesn't have. Then the second one, primary has been progressing well in spontaneous labor at term and pushing for 1 hour, no signs of delivery, vaginal examination, full dilatation at a direct occipital anterior, CTG is normal, and what do you do next? Obviously, this is a primary who is pushing for 1 hour. So you can let her push for 1 more hour, probably she would deliver. The next one, multiparous, forceps, previously had a forceps delivery for failure to progress. And now she's admitted with epidural. She has pushed for 30 minutes, but now exhausted. Vaginal examination, direct occipito anterior at spines. Despite spacious pelvis, there is little descent secondary to poor maternal effort. So obviously, there is a hindering factor. There is a direct occipito anterior and it is at spines. So you can go ahead and do the forceps for her. Okay. Obviously, if there is no analgesia mentioned, it would be if you have an option of trial of instrumental delivery in theater, you could go on. But because they have mentioned she's on epidural, you can apply forceps in the room itself. Okay. So perfect. Fantastic. Let's move on. Okay, again, this is a very random scenario which mentions about the multiparous lady, and she had antenatal care and 2 previous babies were normal. And now breech presentation with the sacro-anterior position. Fetal heart rate is dropping to 80, but it is recovering back. And she's contracting, getting good contractions 3 in 10, and she's distressed with pain. And the baby is descending down well with the contractions. And what do you do with during the only consideration is or only concern is when when she's pushing, there is a deceleration. But rest of the things are absolutely fine. So please make sure you have a team ready and you prepare for assisted breech delivery in the room itself, because everything is fine. And even though there is a deceleration, it is picking up. Just like probably there could be a card compression, that could be the reason. And only during the contraction, it is getting dipped and it is recovering. That's the reason. Okay. Word about categories of cesarean section. Category 1 is always the most urgent one. So like in case of card prolapse or in case of abruption or rupture of the uterus, or CTG like the prolonged bradycardia, or it could be with something like with shoulder dystocia. You need to think of category 1. Category 4 is always an elective cesarean sections. Okay, cesarean section on maternal request. Our previous years who is being posted for elective cesarean sections. And category 3 is somebody was posted, but they came in late, they presented with leaking or a failed induction, you go for category 3. Category 2, all other women who are going to deliver, who is in labor, breech in labor, suspicious CTG, all pathological CTG except prolonged bradycardia will come for category 2. So here, what are we talking about? Basically, category 1 is the most traumatic crash cesarean section. If they are not on any analgesia, it would be done under general anesthesia. Category 4 is an elective one. Category 2 is a semi-elective you can do. And category 3 is something which has to be done, but there is no urgency, but you have to finish on the same day. So a couple of examples for that. Why is this important? Because in EMQ, sometimes you will have things like this, okay? Okay, few factual words. For fetal blood volume at term is 80 to 100 ml per kg. And there is somebody, a multigravida, multiparous, who is 9 centimeters dilated, getting 3 contractions. So 2 hours before she was 9 centimeters dilated. Generally, you reassess in an hour and see. And if the breech is not descending of the perineum, then you have to think of cesarean section, because the extended head is one of the main complications. That's the hyperextended head is very difficult, which can put you at risk of delivering the aftercoming head. The next one, 2 hours before she was fully dilated, now breech at spine, the same lady getting 3 to 4 contractions in 10 minutes. What to do next? Because she has been fully dilated since 2 hours and nothing is happening, you have to go for a cesarean section. We are talking about breech. Okay, so remember, breech is something, it has to be descending on its own. If that doesn't happen in 2 hours, if you don't see the baby descending in perineum in 2 hours, you after fully dilated, please go ahead with a cesarean section. Okay, the next few slides. Okay, what do you do? Obviously, here you need to look into the scenario, a term late, term pregnancy, and 0/5 palpable, left occipito anterior, epidural, good progress from 3 centimeters to fully dilatation in 3 hours, been pushing for 1 hour. So what is this CTG is all about? You can see the W pattern, you can see the variable deceleration. So obviously this is pathological. If you go from here to here, okay, that's what you take as 10 minutes. So it's roughly around 3 contractions and variability is good, but there is a deceleration, variable deceleration with W, this is a late deceleration when you compare to the contraction. So definitely, and you can see there is no shouldering here. Generally, it has to be here and this has to be here, but that is not there. So obviously it is a pathological CTG. So you need to think of going for FPS or scalp stimulation, and probably you can think of cesarean section versus delivery. And a couple of more scenarios. See, here you have a preterm lady. Okay, the baseline looks okay. Variability is little reduced, variable decelerations, and with all, it is repetitive. Vaginal examination, she's only 5 centimeters dilated, blood stain like that. So you're suspecting antepartum hemorrhage in a preterm lady, preterm baby. So obviously, you have to fasten the delivery by category 1. The next one, most appropriate management. What do you do? Here, obviously, you are dealing with a multiparasmen, postterm, and full dilatation was 2 hours before, no descent, and you can see 2/5 of the head palpable. Once it is 2/5, ideally for operative delivery, it should be 0/5, right? And occipital posterior 2+. So obviously, you will not be going for operative delivery. The next thing would be the cesarean section. So, but if you ask me, will this be category 1? No, you can go for this category 2 because the CTG is fine. She just needs the baby to be out. So you can go for category 2, cesarean section. And a couple of EMQs, you could see most appropriate management and what we are dealing with. I usually do not go for the options because it could be confusing for me. So I always read the leading statement and the clinical vignette. So here, what's happening? 20-year, 39 weeks, examined at 10 o'clock, found to be 5 centimeters. Vertex was 2 centimeters above spine. She was re-examined at 14, 6 centimeters dilated. So we are dealing with 1 centimeter dilatation in 4 hours. Vertex is 1 centimeter above ischial spines with contact membrane. So whenever there is a suspicion of delay, I would always want to go for amniotomy. So that's the reason I would choose amniotomy, because less than 1 centimeters in 4 hours. That's the reason. I mean, less than 2 centimeters in 4 hours. So that's the reason I go for amniotomy. And here, what I'm dealing with, like multiparous lady, fully dilated, examined, fully dilated, occipital anterior, vertex 1 centimeter below spine with caput and no molding. So again, because they are not mentioned to me about anything about the analgesias, what she is on, and she has been pushing for a longer time. So I would go for instrumental delivery in the room itself because it is not 0. If it is at 0 and I expect that it's going to be a difficult delivery, I'm going to shift her to the theater. Okay, this I think we have already discussed. So let's move on to the things. Yes, FBS interpretation. You need to know the lactate and the pH. The thing is, pH falls as it moves towards normal to abnormal. Lactate increases when it moves towards normal to abnormal. So whenever you have normal pH with the containing CTG abnormalities, you repeat after 1 hour. When you have a borderline 1, that is 7.21 to 7.24, you repeat after 30 minutes. When you have pH 7.19, you expedite the bath. Okay, obviously, FPS is not done in cases if there is a HIV, Hep B, risk of transmission is more mother to child transmission. And if you think either the case the baby had to be delivered, then no need of doing FPS like card prolapse, abruption. You only do FPS to understand whether you can still continue to monitor the labor. Okay. And obviously, you first thing you can do is a fetal scalp stimulation, which can show acceleration in CTG. That means to say that the baby is still okay to go about. And a couple of things, questions on based on the FPS levels. So 31-year primary, you interpret CTG as pathological. She's 8 centimeters dilated. First pH result is 7.26. Then after 1 hour, second FPS was done 7.23. A third CTG review was performed in 30 minutes. CTG was still pathological. So you are dealing with a thing where you are getting the FBS values do not correlate with the pathological CTG. So it is always mentioned when two CTGs, when two FBS goes in this way and the CTG still remains pathological, before going for third FBS, you have to inform your consultant. And the next one is based on the lactate levels. It is around 4.9. So what do you do? Obviously, because you remember the values which I showed here. So see, 4.9 more than or equal is all these abnormal. So that's the reason you go ahead and you need to be making sure that you will go for the forceps. Obviously, they don't ask the names of the forceps. If you know, it's a good idea. If you don't know, it's fine. And just to rehearse what we discussed before, this was normal, this is borderline. Ideally, even in borderline, you can wait and repeat after 30 minutes, but because there's third FBS, you call your consultant. Here, it is abnormal, so go for the forceps because you can take out the baby quickly. Okay. Second twin, very important. Remember a couple of things: IV access, group and save, epidural. If it is transverse lie after the delivery of the first twin, confirm the lie and shift it to the theater. Try doing ECV. Generally, ECV, always the success rate is not so much because in fully dilated, then you can go for IPV, that is internal podalic version, and assisted breech extraction. That is always been very successful. Remember, while you are doing IPV, you do not rupture the membrane. This has to be done in theater without fail. Here, what is the optimal management? I think we are talking about a woman who is cephalic, and the second one is transverse. So contractions diminish, and it has been 45 minutes since the birth of twin one. Obviously, it is transverse lie. So the next best thing would be internal podalic version and breech extraction. Shift to the theater and try to do the same. Okay. So guys, I have covered most of the important labor scenarios. Obviously, you need to know about the preterm labors. How would you diagnose preterm labor? What do you do for PTROMs? And also the VBAC, the whom you will offer what. Okay, and as well as, I think I touched upon a bit about the breech and card prolapse. You really need to revise your topics and go ahead and probably with these concepts you can work around, because these are the ones which people feel very confused. That's the reason I covered all this. Hope this was useful. Remember, if you only do what you can do, you'll never get then what more than what you are. So try to do an extra effort every single day and you'll be the best in what you do. All the very best. Hope you are liking these RRR series. It is read, revise, and repeat. Okay, so do not forget to subscribe the channel and don't forget to leave the comments about how you felt about this, because these feedbacks and comments help us to do better. All the best and God bless, guys. Thank you so much.